Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to everybody. Thank you very much for joining our webinar this time. I understand that almost 200 participants registered as far as Tawau. Yeah? So we hope people in Tawau are good and okay to join us, yeah, with the current COVID situation. So I'm presenting about infertility for primary care. I'm sure that those who manage in the primary care will occasionally see patient coming with problem of infertility. So how do we manage the patient presented with this problem? Now, infertility is actually a disease itself. Yeah, it is estimated that about 9% of the global population are being affected by infertility. In developed countries such as United States, 1 in 6 couples suffer from the problem of infertility. In developing countries, the figures are actually higher. It is estimated that probably 1 in 4 couples suffer from infertility. And we say infertility, as what the myth thought, this is a female disease. It is not true. It's actually a problem of a union. 1/3 is being attributed to male factors, 1/3 is attributed to female factors, and the balance 1/3 may be because of both female and male factors. Now, when do we define the patient as having problem of infertility? We say the patient may have problem of infertility if they try to conceive for about 1 year of regular unprotected sexual intercourse and they fail to get pregnant. And this is a rough figure because it may change if you see a patient who has problem. For example, you see a patient who is more than 35 years old. You see a patient who has previous history of gynecological history. She has previous history of irregular menses. She has previous history of surgery to the pelvis. She has history of endometriosis, irregular menses. You may not want to wait until 1 year. You probably will start investigating the patient, will start finding what are the cause of the infertility when the patient come to see you, even she is not yet 1 year of marriage. So you may want to start investigating this patient even after 6 months of trying. And why this figure 1 year is being taken, we look at the demographic data where we see with cycle fecundity or ability to conceive in a month is about 22 to 24%. We know that about 86% of the patient who have regular unprotected sexual intercourse would have conceived by 1 year of trying, leaving about 14% who are not able to conceive. But subsequently, if we wait further, we do not see much increment in the number who conceive. So that's the reason why we take the figure 1 year as to a point where we must start investigating the patient. We must start giving attention to the problem the patient is having. And as what we have said just now, it is not just a female problem, it is male and female. Various factors can actually contribute to the problem of infertility. One of it is age. Age is a important parameters because we know in female and male, fertility declines with age, and especially so in female. And other causes of infertility, the most common one is probably ovulatory dysfunction. Being the commonest among the ovulatory dysfunction is polycystic ovarian syndrome. We can also have female with pelvic diseases, either because of sexually transmitted diseases or endometriosis or uterine factor. And male is also, as what we have said before, 1/3 of problem of infertility is contributed by male factor. Now, I would like to bring the attention to this, the effect of age on female fertility, because this slide is very important when we want to approach patients who have problem of infertility. We know that the maximum capability of getting pregnant in a patient or maximum fecundity of fertility is highest at the age between 20 to 30. And after the age of 30, especially so after the age of 35, and more so significantly after the age of 40, the fertility of a female falls significantly. So this graph is very important because we know that the sooner we investigate the female, the sooner we institute treatment for the female, we're going to get a higher chance of success. So it's very important that when we see a patient, we pay much attention to the age, especially so in the female age, because that plays a significant role in the female fertility. Why does the female age has a much influence on female fertility? This is because not only the quantity of the oocyte is reduced as the female get age, it's also the quality of the oocyte is decreased. And this is related to the mitochondrial function of the oocyte, where there is less energy being produced, more granulosa cell apoptosis, and there will be a decrease in the quality because of increment in the oxidative stress. And this is also illustrated by the decline in birth rate. This slide also is very important because whatever treatment that you're going to give to the patient, even you go to the high-tech treatment, for example IVF, the success rate is very much dependent on the patient's age. Even the patient did IVF, the pregnancy rate is going to be lower in the patient who is more than 35 years as compared to the patient who are less than 35 years. Again, it shows the importance of investigating and referring the patient as early as possible so that we can actually start giving treatment for the patient. Now, when we talk about infertility, before the patients are being referred to us at tertiary level, it is important as a primary care to look at factors which can interfere the fertility of the patient. So among the factors which can interfere with the fertility of a patient, among others are obesity, because we know as the patient has a higher BMI, the quality of the egg will become reduced, the quality of the implantation also will become reduced, and the success rate of whatever assisted reproductive technique that we're going to do is also going to be lesser. This is true in both female and also male. So it is very imperative that all patients who are being seen at the primary care level, before being referred to us, please advise them on the lifestyle modification to reduce the problem of obesity. The same goes with smoking. We know that smoking has a hazardous effect on the quality of both oocyte and also the sperm. So it is very important that we advise patients to quit smoking before they are referred to actually for further treatment. And so are other factors which are attributed to lifestyle, for example, infection and also sexually transmitted illnesses, stress and anxiety, and also what are the working environment of the patient or the external environment such as toxic and pollutants, which could actually contribute to the fertility of the patient. Okay. Now, how do we approach when a patient comes to us with problem of infertility? Apart from physical examination and investigation, one of the most important history is actually a good history taking. This must be emphasized because from the history, we can actually have some idea what is the problem the patient is having. One of the most important history is actually menstrual history. If the patient has regular menstrual cycle means cycle of between 25 to 35 days. And if the patient has regular menstrual cycle, this usually means that the patient has no problem with ovulation. Although it is not diagnostic, but it usually points that the patient has normal ovulation. But if the patient has irregular menses, then we must start thinking whether the patient is having polycystic ovarian syndrome or not, because more than 90% of patients who has irregular menses are actually having PCOS. Then we have to ask other history pertaining to PCOS, such as history of increase in hair or history of excessive weight gain and so on. So these are the important history. Number 2 is the coital history. It's very important for patients to tell us about their coital history. Although this is a rather privacy, but when we come to infertility, it is important to ask in terms of frequency, in terms of whether they have complete coitus or not. Not surprisingly, sometimes we see cases who were referred to us because of infertility, but on further questioning, patient actually have problem of coitus. They had not consumed their marriage because of the problem of having coitus. So coital history is also very important. The third, medical and surgical history. This is also very important, because the principle of fertility treatment is that you must make sure that the pregnancy is going to be safe. If the patient has severe medical problem or any medical problem, that must be dealt first before the patient is being treated with the infertility, because we do not want to have morbidity for the mother resulting from the pregnancy that we actually have assisted. So it's very important that the mother is fit in terms of medical and also surgical. And other history which are also important are such as drug history, past obstetric and gynae history, and also social history, because as we said just now, there are lifestyle factors which could affect the fertility. Now, after the history and physical examination, the preliminary investigation that we should do in our infertility patient, in hierarchy, what I usually do in our practice is actually after physical examination, we do an outpatient ultrasound. And preferably, you do a transvaginal scan if you have the facilities. If you don't have the facilities, then transabdominal scan would be the next best option. But TVS, or transvaginal ultrasound, is a good tool because you will be able to see the window to uterus, ovary, any ovarian cyst, any any problem with the endometrium, and also we will be able to see what we call as ovarian reserve, or how many more eggs that the patient have. Okay. If by doing transvaginal scan, we do not see any problem to the female, we see a normal uterus and a normal ovary, the next second examination that you should do is actually seminal fluid analysis. Yeah, because this is an easy examination. We just have to ask the male partner to produce his sperm, and we can actually have an analysis of what is the fertility of the male partner. A number of times I see referral where investigation, more extensive investigation such as HSG has been done to the female, whereas seminal fluid analysis has not been done to the male, and to the surprise, the male has azoospermia. So we don't want to expose the female to unnecessary investigation, so we go by hierarchy. That means after ultrasound, you please do a seminal fluid analysis first, yeah, before you subject the female patient to tubal patency. Now, hormonal assays. In young patient with regular menses, I don't routinely do hormonal assays, yeah, because if you can see that the patient is having good reserve, patient is having regular menses, you don't need to do other assays because you know that the patient is perfectly normal in terms of hormonal. However, if the patient has irregular menses, you may need to do certain hormonal profile, for example, FSH, LH, prolactin, thyroid function, or testosterone, to exclude other than PCOS. Even then, I do not do it routinely if I am confident that this patient is having PCOS. Only if I think the patient needs to be excluded from the diagnosis of PCOS, I'm not sure whether this is PCOS or not, then only we do all the other hormonal profiles. In certain patients where you suspect that they may have low ovarian reserves, for example, patient is more than 40 years old, patient has a previous surgery to the ovary, and you cannot see, you cannot evaluate the remainders of the antral follicle count or the reserve of the ovary, you may want to do certain blood investigation such as anti-Mullerian hormone, which will be able to tell you the egg timer of the patient. How many more oocytes are left for the patient. Okay. And finally, other investigation that you should do is tubal patency, to check the tube of the patient, the fallopian tube of the patient. Now, there are two ways of checking the tubal patency. Either you do a hysterosalpingogram or you do a diagnostic laparoscopy and dye test. If from your evaluation, from your examination, from your history, from your ultrasound findings, you do not suspect that the patient is having pelvic pathology, it is sufficient for you to do a hysterosalpingography. Yeah, and only reserve the patient for diagnostic laparoscopy if you think the patient is having some pelvic pathology, because diagnostic laparoscopy is not without risk, from the risk of general anesthesia and also from the risk of surgery itself. So these are some of the investigation that we usually do at our setup, and some of the investigation can actually be done at the primary care setup. Yeah. Okay. Now, I just would like to illustrate the normal SFA, seminal fluid analysis. You have to look at the count, motility, and also the morphology of the count. Yeah. This is the picture of HSG. From HSG, you'll be able to see the uterine outlining and also the patency of the fallopian tube, and also whether there is any endometrial pathology, because if there is any polyp and so on, you'll be able to see a filling defect within the myometrial cavity. This is laparoscopy dye test, where you can actually, this is a gold standard where you can actually evaluate the uterus, the ovary, the fallopian tube, and also the pelvic factor. Okay. We go to the management. One of the commonest cause of a patient who are being referred to us or we see at our primary care setup is actually patient having irregular menses. Now, irregular menses, you can divide them or into three categories, whether this is hypogonadotrophic hypogonadism, normogonadotrophic normogonadism, or hypergonadotrophic hypogonadism. Yeah. Recently, past few days, we have one case who has irregular menses. She had menses once in every 3 to 4 months. And on investigation and ultrasound, we noted a small uterus. But on examination, what we do is that we send FSH and LH, and FSH noted to be very high, figure about 100, yeah, and low estradiol. So this patient belongs to hypergonadotrophic hypogonadism or premature ovarian insufficiency. She's already approaching menopause, although she is only 20 plus and she's been seen in infertility clinic. So, but the commoner one that we usually see is actually normogonadotrophic normogonadism, which commonly is our PCOS patient. Okay. So in PCOS patient, what is PCOS? Is the most common endocrinopathies that we see. About 5% of female in reproductive age group are being affected by PCOS. About 20 to 35% of patients who are seen in our infertility clinic are actually having PCOS. So they have failure of to get pregnant. They have difficulty to get pregnant, basically because they are not producing a matured egg. They have a lot of ovarian reserve. They have a lot of antral follicle count, but they have hormonal problem which cause the follicle to actually grow into a matured follicle. So for you to be able to diagnose the patient as having polycystic ovarian syndrome, there are what we call as Rotterdam criteria. In Rotterdam criteria, the criteria are irregular menses, number 1. Number 2, they have evidence of hirsutism. Number 3, they have evidence of polycystic ovary on ultrasound. And for you to be able to diagnose the patient as having PCOS, you must have 2 out of 3 criteria for them to be diagnosed as having PCOS. Okay. So among other common causes that we usually also see is endometriosis. Usually patient would present with regular period but having a severe dysmenorrhea, and on our examination, if we do transvaginal scan, we will be able to see an ovarian cyst, and we usually confirm diagnosis by doing a laparoscopy, a diagnostic laparoscopy and laparoscopic cystectomy. And based on the stages of the endometriosis, we'll be able to postulate what are the treatment that we're going to institute for the patient. Also common is problem of male factor. Either it's oligospermia or azoospermia. Okay. Now, infertility treatments vary widely. We can have low-tech or high-tech. Low-tech, which we can actually do in our outpatient, is actually ovulation induction or IUI. High-tech, which require higher technology and laboratory, is assisted reproductive technique, for example, IVF or ICSI. So I'm just going to illustrate a bit on the ovarian stimulation strategies, which some of you can do at your primary care setup. Okay. So ovulation induction is usually reserved for patient who has ovulatory problem. Yeah, means that she has irregular menses and you diagnose her as having failure of ovulation. So you want to try to induce ovulation. So there are various ovulating induction agent that we use, either clomiphene citrate, metformin, letrozole, or even dopamine agonist. So in our setup, the most common that we use is actually clomiphene citrate or letrozole, especially for patients with PCOS. Yeah. So how do we do it? Okay. We usually start with the lowest dose, 50 milligram, day 2 to day 6. And you must document with that dose whether she's having ovulation or not. How do you document? If you have facilities to do a transvaginal ultrasound, you do a transvaginal ultrasound monitoring. If you don't have the facilities, you do a mid-cycle, mid-luteal cycle day 21 progesterone. Okay. If she has evidence of producing an egg or ovulation, remain her on that same dose for about 6 ovulatory cycles. However, if she does not have ovulation with 50 milligram, you're going to increase the dose to 100 milligram. Again, repeat the same things. Do a transvaginal ultrasound or blood monitoring. If she doesn't have also ovulation, increase to a maximum of 150 milligram. If she doesn't still have ovulation up to 150 milligram, then you terminate. You define her as having clomiphene citrate resistant, and this patient would benefit from giving follicle stimulating hormones. Yeah. So these are the way in managing a patient who has been diagnosed as PCOS. Once she receives ovulatory dose, there's no point of increasing the drug anymore, because if you increase, you are putting the patient a chance of having multiple follicular recruitment and also multiple pregnancy. Okay. Metformin is again a drug that we usually give. We usually give metformin in PCOS who are obese, because we know the basis of PCOS is actually insulin resistant, and metformin is an insulin sensitizing drug. Okay. And the other commonly used drug is letrozole. It's an aromatase inhibitor. Therefore, it causes a negative feedback of estrogen, and therefore it increases the FSH. It has the pregnancy rates which are comparable to clomiphene citrate. And I usually give letrozole in a patient who are obese, BMI of more than 31, who also have PCOS, because its response is actually greater to clomiphene. And according to recommendation, the latest recommendation on PCOS management, letrozole is actually superior to clomiphene in subtype of PCOS who are also having problem of obesity. And other drug that we usually give is actually dopamine agonist. Okay. Now we move on to ovulation ART treatment, because the time is only about 5 more minutes. Okay, we have various modalities of assisted reproductive technique, from IUI to IVF. Basically, IUI is a simple technique which you can actually institute in your primary care setup. Okay, it's a commonly offered treatment. It's popular because it's simple, it's not invasive, and it's cost effective. It's the only form of ART available in most government hospital and also GP setup. Okay, it is suitable for patients with unexplained. That means you have investigated and you do not find any abnormality of the patient. It also can be used in mild oligospermia or mild endometriosis, or it's also PCOS who fail to get pregnant with ovulation induction. So basically what we do in IUI cycle is that we usually we give some medication. Either you want to give a clomiphene citrate, you want to give letrozole, or in my setup, I usually give gonadotrophin FSH. So the reason why we give this drug is actually to produce 2 to 3 follicles. Yeah. And once the follicle size is about 18 millimeter, that means she has dominant follicle, you're going to trigger the patient. That means you give HCG, and 36 hours after that, the male partner is going to produce the sperm. And usually you centrifuge the sperm. The reason why you centrifuge is actually to separate the dead sperm from the motile and highly active sperm. And you throw away the dead sperm, and you're going to inseminate the highly active sperm inside the uterus up to the fundus of the uterus. So IUI increase the chance of pregnancy because first you stimulate the patient, so you have more than 1 follicle. Secondly, you're going to inseminate the highly motile sperm at the fundus, and thirdly, you actually insert it at the time of ovulation. But even then, success rate with IUI is only about 15%. Yeah, it's not that great. And subsequently, the highest technology that we have at the moment, if IVF is C, IVF is reserved for patients with blocked fallopian tubes, severe oligospermia, who have failed IUI treatments, or you have moderate to severe endometriosis. So these are the patients who are suitable to go for in vitro fertilization. IVF in EC is just the difference in how fertilization is being done. In EC, you usually are reserved for severe male factor infertility and also some patient who has failed fertilization. So in IVF, what you usually do is that you give high dose of injection with the aim to produce 6 to 8 follicles. And once the follicle reach maturity or the good follicle size, you're going to subject the patient for oocyte retrieval. And oocyte retrieval is totally a transvaginal procedure where under ultrasound guidance, you're going to aspirate all the follicles that we have stimulated and retrieve the eggs. And once you have retrieved the eggs, you're going to fertilize the eggs with the sperm inside the laboratory, either by IVF or ITC technique. Yeah. And once it has been fertilized, you're going to incubate the embryos, for 3 to 5 days inside the laboratory, and subsequently the best quality embryos will be selected for embryo transfer. Okay, so these are the procedures how we do. And in embryo transfer is an outpatient procedures. The best embryos will be selected and inserted via a catheter inside the uterus. Okay, if they are excess embryos, these embryos can be freeze, for future usage. Okay, and in male infertility, severe male factor, for example, azoospermia, don't tell the patient you're not going to able to father a child. You still have investigation to do. That means you can still do testicular biopsy to see if you can still find a sperm, and if you can find some sperm, he has the chance to actually father his biological child. Okay, I'm coming to my end. Some take-home messages for all of you is that first, infertility is a disease. When you see the patient, infertility is actually a disease. You must identify, you must investigate and refer. So infertility is not just a female factor. It can affect both female and male. So it is very important to consult the patient as a union and not just a single. We know that lifestyle may affect fertility, obesity, smoking and stress should be dealt in any couple who wish to conceive. So before you actually refer to us tertiary care, I am very grateful if you can actually advise the patient on how to reduce weight, how to quit smoking and so on before she actually being referred to us at the tertiary center. Okay? And encourage patient to seek treatment as early as possible after 1 year of trying. If a patient comes and see you, don't just say, oh, this is baru 1 tahun, tunggu dulu, come back later. No, you see them as early as possible. The earlier you see, the earlier that you're going to investigate, then earlier you will refer to us, so you have a better chance of pregnancy. Yeah. And majority of patients are actually subfertile and they're not infertile. Yeah. So means that we can offer something for the patient, and there are good chance that the patient is going to have their own biological child for the couple. Now, various modalities of treatment are available in this era, and treatment can only be instituted once diagnosis is established. I must say this because I'm still seeing patients who come for fertility and the next treatment is clomiphene citrate. So I think we should abolish that kind of management. You must investigate. Clomiphene is not a miracle drug that you should give to patient. Yeah, you must find what is the diagnosis first, and then only you start planning what is the treatment that you're going to give for the patient. And finally, not all treatment will give a success at first try. Yeah, some of the patient they face failure. It is very important for us to encourage the patient not to give up and return for treatment as soon as possible. Yeah, so I hope that this presentation will give some idea on how to manage infertility at the primary care setup and how to actually institute some of the treatments modality at the primary care setup. So with that, I thank you. Hope that you all have enjoyed the talk, and stay tuned with us for the next lectures. Yeah, thank you.
Okay, Dr. Murizah. We have 5 questions from the participants. The first question is from Putri Suraya. Hi doctor, I want to ask if the partner refuse for infertility workup, especially the male partner, how do you tackle the issue?
Okay. This is a scenario that occasionally we see in our setup. Occasionally we see a male partner who refuse to come for fertility investigation, especially. So usually we have to know what is the reason that the male is so not willing to come. So probably there are issues there. Maybe he's afraid to know the result. Maybe he doesn't know what he's going to do. So it is very important for us to explain to the male partner. What I usually do is that I usually see the patient in union and explain to the patient what we are going to do. It's a very simple procedure. We encourage the wife to actually assist the husband for masturbation and for production of the sperm. And from then we can actually examine the sperm. So usually with counseling on what to do and to assure him that even if we find abnormality, there are still various treatment that we can offer. Usually with this approach, most of them would be able to participate.
Okay, so second question is from Nur Hafila. Dr. Murizah, how do you check if the patient has ovulation by TVS?
Okay. What we usually do is what we call as basal ovulation monitoring. In basal ovulation monitoring is that you see the patient at the early follicular phase, and then probably if patient has a regular period of 28 days, you see another one at the day 12. At day 12, you expect, if you look at the menstrual cycle, she will have one dominant follicle. Okay? And you see again at probably day 18 to 20, where you see the dominant follicle has actually collapsed or disappeared. So you know that this patient has already ovulated. Okay? Or if you find it's difficult to do a transvaginal scan, you do a mid-luteal progesterone. So if the patient has 28-day cycle, you do a day 21 progesterone. If the patient has usually about 32-day cycle, you probably do a day 23 progesterone. So from there, you'll be able to interpret whether the patient has actually have ovulation or not. Okay, I hope that answered your question.
Okay, the third question is from Zubaida. As we know, no SFA is done in the health clinic. Hence, many referral to HSB have no SFA result. So any advice from you?
Okay. If we can work that out for only to do investigation at our setup, and then that investigation will be brought back for the doctor to evaluate, that also can be done, because some investigation are not done at health clinic. Yeah. For example, you don't do your hormonal profile. Yeah, FSH, LH, you don't do. You only get the blood and you send it for us to evaluate. So probably we can work that way. That means you have an appointment to take the SFA first, and you evaluate back. The result will be sent back to you for you to interpret. So that will actually reduce our queue for our infertility clinic. Our queue is very long queue. So probably by doing that, you can actually evaluate the semen analysis, and probably you can do some modification, lifestyle modification, or repeat the sperm test later before you actually refer to us for appropriate treatment. Or alternatively, you can suggest the patient to do it as an outpatient in other premises. If you do at BP lab, for example, or path lab, it costs you about 60 ringgit if the patient can afford to do that. So I think that is the way to approach, because our queue is actually long for the patient to come and see us. So that probably will have to shorten the duration of investigating for the patient. Okay, that can be worked out actually.
Last question we take from the participant. Actually, we have another few questions, but we have no time left. Any supplement can be suggested for infertility couple?
Okay.
From Fatimah Zahra.
Okay. Now, we are in the era that patient usually takes bags and bags of supplement. Yeah. So for me, the approach is actually to see what is the causative. If the causative factors is, for example, severe sperm factor, so there are specific vitamins or supplement that you can give to the patient to enhance the fertility. Although if you look at the study, there are conflicting results. Yeah, but from our local study, we have local studies on sperm micronutrients. It has been shown that it has a positive effect. So maybe you have to suggest some of the treatment, having known what is the diagnosis. If you have other diagnosis, for example, if the patient has done IVF and you see poor quality eggs, so there are specific vitamins that we would suggest the patient. So it's not like you have to take these vitamins for everybody who suffers from infertility. So you have to go case by case. And what is also very important is actually to suggest the patient on healthy lifestyle modification. That means take healthy food, clean food, yeah, and reduce obesity, and take a lot of micronutrients, natural micronutrients. That are actually the best modalities of treatment actually. Yeah. Okay, so I hope I answer your question. I'm not the one who pro vitamins for everybody. So I think it is best for you to go on natural vitamins. If natural vitamins cannot help, only specific vitamins for specific person. Okay.
Okay, thank you very much, Dr. Zubaidah.
So
We have Dr. Murizah. We have few questions that are not being able to be answered at the moment. We try to give an answer in a written reply. Okay, just keep up with us. Thank you.